Hello everyone, am I audible, visible? A very good evening. Hi, can you guys hear me? Can you guys see me? I hope you can. The chat working. Okay. Hello guys. I hope you guys will join soon. I thought we'll start a new system here. Yes, slowly and successfully completed hematology. Right, so we're done with RPC, WBC, platelets, and also blood transfusion. So we're going to dive into systemic pathology again. If you remember, we had completed blood vessels and CVs already. We're going to start with the respiratory system, and we'll be having respiratory, GIT, renal, urinary, genital system, breast parenchyma, and miscellaneous things, right? We'll be sticking only to the CBME curriculum going forward because systemic pathology is a very, very big topic for you to read everything and memorize everything and remember everything is a very hectic task. And I am also sure that with exam because systemic path is difficult and we'll be going towards whatever is required from exam point of view, from CBME curriculum point of view, right? Good evening, Atul. So maybe in between what I'll do is let me try something different. I wanted to show you a digital slide. If possible, I'll be showing to you as well. Fine. Okay. So with that note, let's start the lecture on systemic pathology. I'll be going with respiratory system. In your CBME curriculum, you have a list of few things catered for an MBBS graduate in your respiratory system. That's your pneumonia, complications, ARDS, and COPD, pneumoconiosis, and your lung carcinoma, right? We'll be going with the same things. In today's lecture, we'll look at normal histology, pneumonia, ARDS, and maybe a little bit of COPD also we'll add on to it, right? We're ready for the game? Let's start here. Since it's systemic pathology, basics are very simple. I want you guys to understand what is normal histology. Once you understand, we're going to use the same concept of acute inflammation, chronic inflammation, wound healing, genetics, neoplasia, and we'll excel everything, right? Same thing what we did for your blood vessel system, right? So histology, my main thing in histology is I'm concerned about the microscopic appearance of alveoli. Other things I'm not much concerned about. The bronchus, bronchial tree, it's not much of a concern for me because if bronchus has a problem, I might have bronchitis, inflammatory condition. When alveoli has a problem, I might have life-threatening conditions. And most of the diseases in the respiratory tree, what you're going to deal will be dealt with the alveoli only, right? The alveoli, I'm sure you must have read about the histology of alveoli in your first year. Just a recap of it, right? Can anyone tell me what are the cells which line the alveoli? What lines the alveoli? Tabasam Atul, Andana, good evening. What do you think lines the alveoli? There are two cells which lines the alveoli. Type 1 pneumocyte, yes, squamous epithelium only, modified squamous epithelium, right? It's a simple squamous epithelium, but we have a different term. We call them a type 1 and type 2 pneumocytes, right? I'm sure you must have heard them. We have type 1 pneumocytes and we have type 2 pneumocytes, right? What do you think is the function of type 2 pneumocytes? Because type 2 pneumocytes is something which you must have learned much in detail when you have dealt about embryology and the maturation of lung also. Type 2 pneumocytes secrete something called as surfactant, right? They secrete surfactant. That's a primary function of type 2 pneumocyte, surfactant synthesis. If you remember surfactant's function is to alveoli is it's an air sac. The air sac should be maintained like an air sac. Otherwise, if you blow, let's take you have a plastic cover, you blow in air into it, automatically it will collapse. Alveoli cannot collapse like that, right? Surfactant is the one which makes the surface tension very smooth, uniform, so that alveoli doesn't collapse completely. It shrinks, expands, right? Surfactant is very, very important for me. Type 1 pneumocytes, on the other hand, it helps in the air-gas exchange. Okay? It helps in simple air-gas exchange, and type 2 pneumocytes is going to help in surfactant synthesis. Yes, they are squamous epithelium. The lung is lined by simple squamous epithelium. It's not stratified, a simple squamous epithelium. They are termed as pneumocytes. It's a modified name given because it's lining the lung alveoli. So we call them a pneumocytes, right? Basically, histologically, yes, they are squamous epithelium only. Okay, I'll come back to this. Right? So when you have lining epithelium, there are two things here. How do they look? A type 1 pneumocyte is generally very flat. It's a simple squamous epithelium. Endothelium is also a simple squamous epithelium, right? It's a very, very flat epithelium. It's going to look like this. Type 2 pneumocytes, on the other hand, it has a very peculiar appearance. This appearance also came once in exam. It looks like this. The nucleus will be in the tip and it'll have a stalk, right? This appearance is called as an hobnail appearance, right? You might not see this hobnail appearance in a light microscopy because it's a very low power image. You will not see them. I'll show you light microscopy on alveoli. But this is how type 2 pneumocytes look. Type 2 pneumocytes are there, but they are not in plenty. Type 1 pneumocytes are in plenty. Obviously, has to be air gas section, right? So let's say I have one more alveoli here. What do you think will be there between the alveoli? What is the space called as? I'm sure you know that the space between the alveoli is called as, they have a name, we call them interstitium, right? The space between the alveoli, I'm going to call them an interstitium, right? So this is an alveoli, this is an alveoli. In between, I have an interstitium. Can you guys hear me? Am I audible? Sorry, just give me a second. Am I audible? Okay, great. So type 2 pneumocytes and type 1 pneumocytes, and there are two spaces here, two alveolar spaces. What is the space between the alveoli called as? What do you call them? The space between the alveoli, what do you call them? We call them an interstitial space, right? The interstitial space, space between anything, space between two cells, I call them interstitial. Space between two alveoli, I call them interstitial. Space between two muscle fibers, we call them interstitial, right? So this space we will term as interstitial spaces. So what do you think you will have an interstitial space? The previous one was better. Yeah, I thought this one will be better. What do you think will be there in an interstitial space? Anything which comes to your mind? Interstitial space, one important thing is air gas exchange, right? Here it's what I have the air, right? This air has to go into my blood vessels. So the entire interstitial space or the space surrounding the alveoli, you will have, yes, connective tissue for sure. The most important component for me is blood vessel, the alveolar capillaries. In a normal alveoli, interstitial space will not be even seen. Very, very thin. I just will have capillaries, and like Tabasam said, I'll have few connective tissue, few fibroblasts, few collagen, very, very minimal. In a normal alveoli or a normal lung, interstitial space will not be at all seen, right? This is an alveoli. Look at this alveoli, alveoli, alveoli. All these are alveoli. In between, you're not seeing anything at all. It will be just very thin rim, a very subtle compressed capillary, few fibroblasts here and there. Maybe this place you can see them prominent. This place I can see them prominent, right? There's a space between the interstitial, space between the alveoli. I can see some connective tissue here, but generally I don't see many things. It's just there. I know it's there. Unless it's involved pathologically, I will not see anything, right? Just let's see how good your histology is from your first year of MBBS. If you look at this, am I right in saying that this, whatever I'm drawing in dotted lines in alveoli, it's an alveoli, right? So if you look at this, I'll draw one more alveoli in black color. If you look at this two, these two alveoli has a connection, right? They are connected. What is the space called as? I just erase this color. If you can look, there's a color alveoli which I've drawn pink color. On the top, I've drawn an alveoli which is black in color. These both are connected by space. And look at this. This is an alveoli, then alveoli. These both are connected by a space. They are not individual. They are not separate air focus. Yes, it's an interalveolar space. You must have heard this for sure. Have you heard about something called as spores of Kahn? You must have heard something called spores of Kahn, right? You must have heard for sure, right? The pores of Kahn. This is very, very important because let's say if I have this alveoli involved by an infection, is there a possibility from here you go to here? It can because they're connected. They'll be connected for sure. The alveolar spaces will be there. In between two alveoli, they'll be connected. So when you have an infection of one alveoli, it doesn't involve one alveoli. It involves an entire segment. That's why pneumonia is involving lung consolidation. It's not one alveolar infection. If one is involved, automatically it spreads to everything else, right? Because via the pores of Kahn, right? Okay. So that's about your normal lung capillary and normal alveoli.
You have to know normal. If you know normal, abnormality is simple, very, very simple, right? Just to recap, I have an alveoli. I have the alveolar lining epithelium, type 1, type 2 pneumocytes. Type 1 pneumocytes functions to just one air gas exchange. Type 2 pneumocytes functions just surfactant synthesis. Surrounding the alveoli, you have alveolar capillaries and your interstitial spaces. So how do I group disorders of alveoli or lung is lung epithelium can get damaged, lung capillary can get damaged, lung interstitial can be a problem, right? So all these are problems here, right? So when we group disorders also, we call them as COPD. Atul, I'll tell what does consolidation mean. Just give me a few minutes. What does COPD means? We will read about restrictive lung disorders. We'll read about lung cancers. We might not read about pulmonary hypertension pathology. You'll read them in medicine because CBME doesn't care about pulmonary hypertension. We're not going to read them, right? But I have a disease either involving the alveoli or I have a disease involving the interstitium, right? This is how normal alveoli looks. Now let's go to the abnormality. The abnormality, I'm going to go to pneumonia. If you're in your classes, if they started taking lung pathology, what are types of pneumonia you know? Or if you have read lung pathology any time, do you know any different types of pneumonia? How do we classify pneumonia? I'm sure Dr. Mamta must have taught you about organisms. Right? How do you classify pneumonia? The first thing for me is classification. The classification of pneumonia per se can be asked as in 2 or 3 mark questions. How can you classify pneumonia? Perfect. One is what Atul said, lobar. What is the other one? Lobar and bronchopneumonia, right? That's one. So when I classify pneumonia, I can classify it based on organisms causing them. That's the first classification. Like in simple terms, I call something as bacterial pneumonia. Bacterial pneumonia are also called as a typical pneumonia. I'll tell you why we call them a typical. So other thing, instead of calling them viral, I'm going to group all the intracellular organisms. Can you name any one intracellular bacteria? Intracellular organisms. All these intracellular organisms, which includes virus, you must have heard about chlamydia, perfect, mycoplasma, legionella, all these are intracellular bacteria. Why I'm grouping them is virus is intracellular. These bacteria are intracellular. So my host, my immune system will act the same way against any intracellular pathogen. These I'm going to call them atypical pneumonia. Tabasam will leave TB. TB is has a separate kingdom of its own, right? Obviously, we'll have tuberculosis pneumonia also. So group them to bacterial, intracellular, or atypical pneumonia. These are the broader categories as per the organism surveys, right? Second thing, whatever Atul said, it's actually the effect based on the gross pathology, gross images. You must have definitely seen in your pathology museum gross samples of lung where they'll be telling there's a lobar pneumonia, there's a bronchopneumonia, right? So I have two broad classifications. I call them a lobar pneumonia and we call them an bronchopneumonia. The easiest way to identify them is it's lobar pneumonia. So what do you think will be affected? Then the name. One or more than one lobes of the lung will be affected. You know about the lobes of lung, right side and left side, different lobes, 3 lobes on the right and 2 lobes on the left, right? If either one entire lobe or more than one lobe is affected, I'm going to call them a lobar pneumonia. So how do you identify bronchopneumonia? So the pneumonia, if the pneumonia is nothing but infection of the lung parenchyma or inflammation of the lung parenchyma, if it's going to be involved surrounding the bronchus, I'm going to call them not the mainstream bronchus, maybe the classified downstream bronchus also. I'm going to call them a bronchopneumonia. So how do I identify them is here, it's either one or more lobes. Okay? Here it will be the most important identifying factor will be this will be multiple tiny areas. Because broncho, it's not the entire lobe, right? I'll show you two images, both are from Robbins, and I want you to tell which is lobar, which is broncho. It's very, very simple to identify. Let's name it one, let's name it two. Which you think is lobar? Who is online? I want you guys to answer, which is lobar pneumonia. Obviously, second one is lobar pneumonia, right? If you look at this, the entire lung, the entire lobe of the lung here is white in color. Okay. Now coming back to Atul's question, do you think this side of the lung is having air gas exchange, or do you think it's gone? Will this lung have an air gas exchange or not? It will not. This is what I call them consolidation. Consolidation, in the simplest languages, it is a non-aerated lung tissue. That's the definition. If a lung tissue is not getting air inside, it becomes firm. Have you touched lung in your anatomy? Cadavers, have you touched the lung? Have you felt the lung in anatomy cadaver? If you felt lung is like a sponge. Lung is always aerated. Lung is spongy. If lung loses spongy texture and becomes firm, I call them consolidated lung, right? So this is lobar. It's entirely gone. Entire lobe has become white in color, right? On the other hand, I'll just zoom this image. Can I say here in this, whatever I'm drawing, does this area looks firm and consolidated? Yes, it does look firm and consolidated, right? Let me draw in yellow color. Can I say this part of the lung parenchyma, which I'm drawing in yellow color, is kind of looking normal? Yes. When you compare the color itself, you can say that yes, this is definitely consolidated and this part is definitely normal, right? So I have a consolidation, I have normal, and there are patchy areas of consolidation here, right? When you have patchy areas of consolidation, that's the easiest one, that's the easiest clue for you. Even in your question, if you have a lung gross spotter given, use the term patchy. Patchy, multiple areas of firm appearing lung. Call them a bronchopneumonia, right? That's patchy. I'm going to call them a bronchopneumonia. When it's complete lobe, it can be one or more than one. I call them a lobar pneumonia, right? So there's a gross classification. How I classify pneumonia based on the appearance of the lung parenchyma. Gross classification can also be used on an X-ray. X-ray also I can see non-aerated lung. It look white in color. Patches of consolidation, bronchopneumonia, right? Can be done on X-ray, can be done on a CT, can be done on gross imaging, right? Next. Third is route of transmission or route by which the infection is acquired. Okay? So the place by which infection is acquired, we give a term to them. One, we call them, this is the latest classification being commonly used. We use the term community acquired pneumonia. It's a very, very broad term here. So when I say community acquired pneumonia, I'm there. Let's say I have a friend of mine who has a lung infection. I speak with them, I stay with them. There's a possibility the guy will cough. The organism from them can come to me. Community acquired. The second thing is nosocomial. So what do you think is a place where nosocomial infection or nosocomial pneumonia can happen? What does nosocomial mean? You must have heard of, in microbiology, there are a group of infection called as nosocomial infection, hospital acquired, right? So we have nosocomial pneumonias and we have community acquired pneumonia. So this is not particularly need not be viral or bacterial, doesn't matter. If you have worked in COVID ward, if I got a COVID infection in hospital, I call them nosocomial, that's all. I can get the same COVID in the community also. The nosocomial community is based on the route by which I acquire the infection or the place by which I acquire the infection is in the community or in the hospital. I call them community acquired and I call them nosocomial pneumonia. Right? So pneumonia means infection or inflammation of the lung parenchyma, and we divide them based on the organism. We divide them based on the lung gross or imaging wise, and we divide them based on the way by which I acquire the pneumonia. Right? This is basic. Now for us, this is a main classification. The reason why this classification is important for me for pathogenesis is bacteria, my body reacts differently. Intracellular or virus, my body reacts differently. So I have to need to know how my body is going to react. And we also know why I call them a typical and atypical pneumonia, right? Let's go to that, right? The first thing for us is we are going to read about bacterial pneumonia. Can anyone tell me any one organism which causes bacterial pneumonia? Though Robbins gives a very detailed approach of every organism, I'll leave to Dr. Mamta. She is a microbiologist. She'll be definitely way better than me in explaining about the organisms, right? Any one organism which can cause pneumonia? You must have heard about Streptococcus, Staphylococcus, Pneumococcus pneumoniae, Klebsiella pneumonia, right? There are multiple bacteria which can cause pneumonia. Whatever may be the bacteria, the template by which my body is going to act is more or less the same. It will not differ, it's more or less the same, right? Let's assume the route of entry came via inhalation. It came via inhalation route, and this came into my alveoli. My respiratory bronchial cilia failed to stop them. It reached my alveoli. Right? Once it reached my alveoli, let's assume that this is your alveoli and you have bacteria. So now I'm having bacteria in a place. What do you think should happen? Should acute inflammation happen or not? I want you to answer every step because once you answer every step, I'm just going to put that in lung parenchyma. That's all. Will acute inflammation happen here or not? Yes or no? I'm having bacteria here, and there's my alveoli. It should happen, right? Obviously. If acute inflammation has to happen, and actually acute inflammation has to happen, what is the hallmark of acute inflammation? Tabasam will go to macrophage. Before that, I have one thing. What do you think is the hallmark of acute inflammation? I'm sure you guys know the hallmark of acute inflammation. Way back to second chapter. Swelling is gross, right? I want what happens in the tissue. Swelling is naked eye finding for me. What do you think will happen? What results in swelling is a thing which I want. Before neutrophils, I have one more thing before neutrophils coming outside. Can I say the first step in any acute inflammation is vasodilatation and increase in vascular permeability? Yes, like Sabasam said, histamine will come and vasodilatation is the first part. So am I right in saying that the same vasodilatation can also happen in the lung alveoli? It has to, it will happen for sure, right? So once my bacteria came into the alveoli, these green ones are my bacteria here, my body is going to react the same way. Be it a pimple or my lung, it reacts in the same way. The first step for any acute inflammation, I'm just writing on this corner the steps of acute inflammation, and on this side we'll see what will happen to the lung parenchyma. Right? So the first thing is vasodilatation, okay, and increase in vascular permeability. Okay. Now it's vasodilatation and increase in vascular permeability. I'm having alveoli. Which vessels will dilate? Capillaries seen surrounding the alveoli will definitely dilate, right? So because of this, the first step for me is very, very simple. See, our goal is simple. Throughout the lung, what you're going to read is microscopy, gross, clinical findings. If we can relate microscopy, gross to clinical findings, enough. Because you're going to see patients. By the time you see patients, you can remember and you can imagine what's happening to the lung. Not just lung, every organ system you're going to do the same. So I know what should I do to treat here, right? So here, let's say the patient is going to have in microscopy, we'll go with microscopy because that's our forte, right? So there'll be capillary dilatation. That's all it's going to happen. So the perialveolar capillaries will dilate. So let's assume this is my alveoli. Just for understanding, let's assume this is a normal capillary. Just for understanding, let's assume this is a dilated capillary, right? Maybe we'll draw it red in color so that we know it's a capillary here. The capillary is undergoing dilatation here. Again, still, just for understanding, my bacteria are happy inside, right? When the capillaries are undergoing dilatation, bacteria is there inside the lung alveoli. Do you think air gas exchange will happen here or not? Will there be any concern in air gas exchange? Yes, no. Are the pneumocytes normal? They are normal, right? Will there be any concern in air gas exchange? Completely normal, right? So here my capillaries are dilated. My alveoli has no problem. I have bacteria inside, that's all. But it's not being destroyed, not being filled with something, right? So definitely here, in this condition, air gas exchange is normal. Okay. When this is normal, what do you think will the patient symptom be? What do you think will be the symptom of a patient? If air gas exchange is normal, what do you think will be the symptom of patient? Can I say it will be very, very non-specific to infection? That's all. I won't have anything. It'll be non-specific to infection, right? So symptomatology for me here is simple. It'll be non-specific findings. The patient might have fever. That's all. I won't have any localizing symptom. I won't have any breathing difficulty because lung, there's no problem at all for me. Lungs function is normal. Symptom is asymptomatic. The patient have non-specific symptom like fever, body ache, something of that sort, right? Now, if you look at gross appearance of lung, it's just for theoretical thing. No one is going to look at the gross or microscopy. What do you think will happen to the weight of the lung? I'm having vasodilatation. Imagine almost like 50% of the capillaries in the lung is being dilated. Can I say the lung will become heavy? Right? The exact term given in Robbins is heavy and boggy. Increase and become full of blood. It's a congested organ, right? So can I say to this entire stage, can I call this stage as stage of congestion? That's my first stage. I'm just equating to whatever we read in vasodilatation. The same thing like Tabasam said, it will be same histamine, same selectin, same integrin, everything will happen, right? So this is the first stage of pneumonia, We call this a stage of congestion. It's just congested here. After this congestion, what will happen is slowly vascular permeability will increase because my endothelium will give back gap, right? When my endothelium gives gap, just I'm asking you a random question, not related to pneumonia at all. My endothelium is separating. Who do you think will easily go outside? RBC or WBC? Which will be maximum in number? My endothelium gives way. Who will go maximum outside? RBC or WBC? In any inflammation, who do you think can easily go outside? It'll always be RBC, right? The WBC is important for me, but RBC is the one which will go outside very easily. Give me a second, Atul. Because the number WBC is 10,000 per cubic mm, but RBC is like 4 to 5 million per cubic mm, right? A very, very high number. So RBC goes outside. I'm not saying WBC will not. Within a few hours, my body will understand, okay, RBCs, you don't go outside. Just because you have an opening, you should not go outside. Just wait for it. WBCs are needed for me. Over the period of time, WBC will predominate, right? Since the first opening happens, it goes outside. Atul, coming to the heavy thing, it's just an it's just normal lung with 1 unit of blood supply. Here, every lung capillary is becoming dilated. So I'm having 2 or 3 units of blood supply. If the blood supply increases, obviously lung grossly will heavy and it will be boggy, right? That's what it may heavy and boggy, right? Second, next stage is going to be increased permeability. Due to the sheer nature of the amount of RBCs, so it will be initially more amount of RBC. I'm not saying there'll be no WBC, there'll be WBC also. WBC also will come outside, right? So once it comes outside, let's see how lung looks. Again, we are going to do the same. We'll know what is the microscopy. You will tell me what will happen to the patient. You will tell me what will happen to the X-ray, and you will tell me what will happen to the gross as well. It's very, very simple. I'm just going to tell you what happens in microscopy. That also I didn't tell. You told it. Okay, now I'm having lots and lots of RBC. I didn't say WBC will not be there. Yes, WBC also will be there. Okay, fine, perfect. This is what's going to happen. This for our example, our alveoli and the capillary. Tawasam, I'll come to your question soon. Right? So now what happens is I'm having lots of RBCs and WBCs inside the lung alveoli, right? Do you think in this alveoli, air gas exchange can happen properly or not? In other words, imagine you are drowning inside a swimming pool. Do you think you'll have normal breathing? The entire alveoli is made of a liquid or cells. Air gas exchange will not happen. If the air gas exchange is not happening, the lung will be soft or firm. The lung will be firm, right? Become firm. So it is said that when you touch the lung in this time, it will be very firm like a liver. So we use the term hepatization. Feels like a liver. So we call them hepatization, right? So here it's a very, very this is what happens in the second stage. I'll just name them stage two. We'll name the stage two soon. Here, this lung is they are non-aerated. It's non-aerated lung, like we said first, we are going to call them consolidation. This consolidated lung, like you guys said, grossly it will be firm. Once it is firm, it will not feel like a lung, it feels like a liver. We call this stage is called as a stage of hepatization. Okay? Stage of hepatization. Now, stage of hepatization, should I call them red hepatization or white hepatization? Since I'm saying there'll be lots of RBCs, we give a prefix stage of red hepatization. Right? This is what happens, stage of red hepatization. And it'll be firm and it'll be slightly red in color because of the RBC nature, that's all. Now here, tell me, what do you think will be the patient's symptom? Will the patient have breathing difficulty? Will there be breathing difficulties? There will be breathing difficulty, right? There will be breathing difficulties for sure, right? The patient will have breathing difficulty. Here, my symptoms will be specific to the lung. In addition to my fever, In addition to the body ache that will persist, now the lung will also have a problem, so I'll have breathing difficulties. We call them localization of symptoms. I know something is wrong. Auscultation. Now, again, have you started auscultating patients? Because systemic pathology is something, if you link with medicine, it will be really amazing. You need not memorize anything. Have you started auscultating patients? Anyone? No? If yes, we'll try to extrapolate what happens here, right? Two more things here. Then you look at the image seen here. One for me is I have to imagine, I have to understand how it looks on X-ray. I have to imagine and I have to understand how it looks on a clinical examination. If you're able to connect this, that's enough. You don't want to memorize anything. Now, you must have seen a chest X-ray, right? What's the normal color of lung in a chest X-ray? White or black? It's black because the lung parenchyma has alveoli. Alveoli is filled with air, which is transparent. Perfect. Now I'm saying, let's assume this is a lung shadow. Okay, fine. Fully black. I cannot draw it black in color. Okay, let's assume it's black in color like this. Full of lung is normally black, right? Now tell me, if it's normally completely black like this, if I have in this any area consolidation, which is no aeration, not breathing properly, it will become white or black. The consolidated foci of the lung will become white or black in color. The consolidated foci, it will become white in color because not aerated, right? So it becomes like this, like this. So now tell me, if I'm seeing lung X-ray with multiple patches, lobar pneumonia, bronchopneumonia. Perfect, it is bronchopneumonia, right? Multiple. If I'm saying, okay, this how lung is, entire thing gone. If entire thing is gone, can I call it a lobar pneumonia? I can call it a lobar pneumonia, right? So that's how I can easily pick up lobar pneumonia or a bronchopneumonia even on X-ray. So you know how your pneumonia looks on X-ray. Next time when you go to a ward, if you have a patient with pneumonia, take the X-ray and see. That completes the cycle. You see them once, you'll never forget. Next, when I see the X-ray, I don't want you to diagnose with X-ray. You have patients and you have stethoscope and we have a brain. We are going to diagnose with clinical examination. I wanted to suspect everything with clinical examination, then maybe we'll do the X-ray, right? Now let's assume. Have you heard the normal breath sounds? You must have heard the normal breath sounds, right? The expiration, inspiration, everything. So here, then consolidation there. The consolidation, we have a type of breathing called as bronchial breathing. Okay. So how do we pick up bronchial breathing? Is from the name. It's a bronchial breathing. After this class, take a stethoscope. Maybe use your friend or mom or dad if you're at home. Auscultate the lung, listen to it, register in the head. Then put the stethoscope in the bronchus, auscultate there. Normal, normal bronchus. Listen to the sound. Get used to it. This sound is different from the sound here because this is an hollow space. There's no alveoli here. It goes like that. But here it's different because it's pushed, right? So the lung sounds will be different in normal alveoli. But if I'm having a consolidation, the sound looks like a bronchial breathing. You can easily tell by auscultation, you can tell which lobe of the lung is involved. That's so perfect I can identify. I use X-ray to confirm my diagnosis, right? So when I have a stage, you can do with everything. Now coming back to your question, Tabasam, I am not saying that WBC will, RBC is the one which will be coming out predominantly. WBC will come outside. The reason why I'm saying is WBC's role is here is very specific. Am I right in saying that in every inflammation there will be edema? Yes. Edema cannot be due to WBC alone, right? Plasma will come outside. When plasma comes outside, RBC also will come outside. Edema is inherent of every inflammation. Edema cannot be due to WBC alone. Everything comes outside, right? Okay. Just give me a second. I'll explain. This is the image from Robbins. Just I'll draw the outline here. If you look at this outline, if you look at this, inside you have blue dots, which means I do have WBC, plus I have RBC. The congested early stage, it looks red in color, so we call it red hepatization. Right? So why bronchial breathing? have you, what's the best example I can give you? See, lung alveoli is like a honeycomb. When I blow the air into a honeycomb, it gives a different texture. I blow outside, it'll have a pushback. It'll have a pushback. But a consolidated lung, the lung air might go inside, but it might not be staying there. So it's going to reflect them. So if you go through and have you ever walked inside a, I'll come to your question. Dabba. Have you ever walked inside a tunnel? If you ever walked inside a tunnel, if you peak, it'll repulse back, right? So a consolidated lung will hit and come back. It will not take it inside and let it outside. When it hits and comes back like a tunnel, it sounds differently. Next time, if you have a tunnel or a subway, go into a subway and speak. The tone will be different. That's a bronchial breathing. A consolidated lung is always like that. That becomes a bronchial breathing. Right? Okay. Yes, Tabasum, when I say whole lobe is involved, this whole lobe alveoli is having infection. Only then will be involved. If it's bronchopneumonia, it's restricted here, so it's involved. That's all. You are right. Wherever the bacteria is, that only I'll have inflammation, and that part of the lung only will be involved. Based on the virulence of the bacteria, it can be whole lobe like Klebsiella, very virulent, maybe Streptococcus, tiny, the part of the lobe. Fine. And let's go to the next stage. After this stage, what happens is consolidation will persist. RBCs will slowly move away. Second, what happens is after this, I'll have increase in WBCs, not this them. I'll have a little bit of increase in fibrin also. The reason for fibrin coming here is its vessel is being expanded, capillaries might have some damage. So this is called as an fibrinous exudate. It's not fibrosis, it's a fibrinous exudate. This is my stage 3, where my entire alveoli, we just draw the alveoli again. Inside that, I'm just drawing pink color for fibrin here and there. That's exudate. It's still WBCs. Still the WBCs which is there here and there. Full of WBCs and exudate. Here, my body is fighting back, trying to eat the bacteria and destroy the bacteria, right? In this stage, same few things. This is my microscope, right? What do you think will be there in gross? Will it be consolidated? Normal. Second, X-ray. Third, symptom. Will be consolidated or normal? Has to be consolidated, right? But here, it's kind of becoming more organized. It's becoming more organized because of the fibrin state. So do you think the red color will still stay or will go away? It will go away, right? So here I'm going to have something called as an whitish color. So this stage is called as an stage of gray hepatization. Okay, it's same hepatization because it's firm like a liver, and it's not red in color because the congestion is gone. So it's going to be stage of gray hepatization. X-ray same. It will be whitish in areas. Symptoms same. It will be still restricted to respiratory difficulties. It will be there based on the involvement of the lung. Entire lobe is involved. SpO2 might fall. Otherwise, just breathing difficulty on and off. That's all right. Next. So in this stage where fibrinous exudate comes, which means my body is kind of took care of the bacteria, ate the bacteria. What is the next stage? Here is where all the fibrin came, my bacteria became more, my WBC came, ate the bacteria, destroyed everything. This stage is where I achieve success. What's the next stage? You know normal infection inflammation. If you know that, you know this. What's the next stage? I want to get to answer that. Only then I'm going to the next topic. What is the next stage? Macrophages comes here. Macrophage eat them and starting to do everything. Yes, macrophage will come. Here is where I achieve success. I remove everything here. What's the next stage? Next stage is resolution, right? It will resolve, right? So after this, the next stage, I'm going to call it stage of resolution. The only problem here is Yeah, I'm going to reduce inflammation. I'm going to resolve. I'm going to start healing. This is always by what mechanism? Wound healing is always ends in what? It always ends in fibrosis. It also ends in fibrosis. The biggest concern for me is if I have a skin, I have an acute inflammation in the skin. Do you think I have any? Will there be any scar in skin in acute inflammation? Will there be a scar in skin? Won't have, right? I won't have scar in skin because skin is a bit firm. It's an alveoli. Imagine a balloon having an inflammation with so much of bacteria. Will the balloon rupture? Even for an acute inflammation, it will have damage. When the damage is happening, when it heals, will there be a scar formation? There will be a scar formation. Right? Here's the stage of resolution. Since alveoli are very, very flimsy structure, and all these bacteria and all the WBC which came will release its enzymes, will destroy everything. Macrophage will come, it'll organize fibroblasts, it'll end up in scar formation, right? This is equivalent to my stage of wound healing. Okay, equivalent to wound healing. For sure, here there will be fibrosis. It will be present. This is my stage. You can look at this. It's for comparison. The normal alveoli you can see here, and compared to that, obviously this side, whatever has been drawn in blacker, has no alveolar spaces because completely blocked by fibrosis. This is what I have here, right? Let's see. These four stages is not important for me at all. This era, I don't care about the four stages. Right? I'll just name the stages. Stage of congestion, red hepatization, gray hepatization, resolution. This is what my body does when my lung has a bacterial infection. Right? Now tell me, do you think you are the doctor treating the patient? Do you think you would lead to stage of resolution or you want to tackle before resolution happens on its own? Because if resolution happens, lung will have fibrosis. If there is fibrosis, it's reversible or irreversible? This irreversible, right? So I cannot and I will not lead it to fibrosis. So I have to stop before fibrosis. That's where your clinical examination comes. It's always the patients. The first initially, see, let's take an example of COVID only. Because we know everything about COVID, you must have dealt with COVID friends, family members some point of time. Look at COVID. Initially, I had fever in COVID. That's my stage of congestion. I didn't bother much. When it came to the second stage, though COVID is virus, it will not follow the same stage. I'm just giving you an example. When the patient started having cough, like, okay, something is wrong. Let me monitor the SpO2. When it goes to the next stage, the SpO2 is dropping, so there's more damage. I will have to treat. I should not let the fibrosis come inside. So what we do now is, this stage, I'll give antipyretics, no problem at all. When breathing difficulty happens, I'll give antibiotics. In a real life, in this era, this four stages doesn't happen. I intervene at the second stage. I give antibiotics. So I don't let the WBC destroy the bacteria. I let the drug destroy the bacteria. The advantage of that is when drug destroys the bacteria, will it have wound healing by scar formation? It will not. When you give antibiotics, we reduce scarring. That's very, very important, right? That's why I have to intervene. Now let's say you missed 3, 4 days. You're starting antibiotics in this stage. Do you think you'll have scar formation? Have scar formation because you have missed it, right? Or it'll lead to complication. So the timing of treatment is very, very important. So the monitoring is very, very important. If there's a consolidation or a bronchial breathing, start antibiotics. Even IV antibiotics. There's a deep-seated infection. Start IV antibiotics, give for culture sensitivity, and do see what will happen, right? Now, there's one more thing which I want to add to this. The patient's lung is extremely congested. I'm having lots of uh, WBCs, fibrinous exudate inside the alveoli. Patient will have cough. Will the patient produce sputum or not? Will there be cough only or cough with expectoration? Because everything is there inside the alveoli. Will there be cough with expectoration or only dry cough? The best way to identify bacterial pneumonia in a clinical history is This will be the clinical symptom most of the time. Fever generally will be high grade with or without breathing difficulty. The breathing difficulty is generally based on the stage of pneumonia, right? Plus, almost always with sputum production. This is very, very classical. I'll tell you why this is important very soon, right? It'll always be associated with sputum production because the entire alveoli is having neutrophils. So obviously, the neutrophils might come into the bronchus, you will split it outside. So when you have sputum production, I'm going to, in a case of a pneumonia, I think of an bacterial pneumonia. We call this a typical pneumonia. Fever with localizing symptom of sputum production and cough, we call it a typical pneumonia, right? Keep this in mind. I'll use this when it comes to atypical pneumonia because the symptoms are a bit different, that's all. The complication. You're going to tell me the complication, right? Let's say I'm not able to treat back with antibiotics or my body's immunity is not so good, right? And what do you think will happen here? Can this amount of WBC, will they be capable of destroying the entire alveolar bridges? Can they do that? My immunity is poor and I'm not able to treat with antibiotics. Can it destroy? I'll come to questions, Abasim. Just give me a second. Can it destroy? It can destroy. Right? If it's my immunity is poor and if the organism is very, very virulent, it can completely destroy. If it destroys, it'll not be one alveoli, it'll be like a sac with WBCs, with your pus cells. It can result in abscess formation. I'm talking about complications. I'm talking about scenarios which are not expected in a normal individual, right? First thing for me is abscess formation. Lung abscess can definitely form, right? Tabasam, coming back to the question, the classical color of sputum is called as rusty brown sputum. Generally, you don't see rusty brown sputum at all. Yellow to green only, like you said, because the color of neutrophils is yellow to green, right? Mostly it's that only. But in textbooks, in your exams, it'll be rusty brown sputum. There is some type of sputum called as recurrent jelly sputum. That will be a clue for telling it's a Klebsiella pneumonia, right? When you go to medicine, you will see few clues. With the color of the sputum, I can suspect, okay, this is the most likely type of pneumonia, right? Okay. Abscess formation is possible in two scenarios. When you have a very, very virulent organism, if the organism is very, very aggressive, like Klebsiella, aggressive organism, pneumococcus is aggressive. Staphylococcal might not be, but pneumococcus and Klebsiella are sometimes very virulent. It will destroy everything cause your abscess formation. I'll, let's see how much you can, how do you remember, how much you remember. I want everyone to answer this question. What type of necrosis will be seen in abscess formation? Or there should be an less like immunosuppression, HIV AIDS, it can cause. What type of necrosis will be seen in abscess formation? Abscess. It is only when it's tuberculosis. Abscess formation is liquefactor necrosis, right? When there's more pus cells, bed gangrene, abscess, acute pancreatitis, everything will have liquefactor necrosis, right? Is there a possibility from the lung it can go into the pleural space? It can, right? It can definitely go to the pleural space, right? When it goes to the pleural space, pus in the pleural space, we call them as empyema thoracis. Here, I'm going to have pus in the pleural space. It's again aggressive, same risk factor, very aggressive organism or less immunity can spread. Can it also spread to the uh, bloodstream? It can result in sepsis. Whenever it results in sepsis, most likely associated with ARDS. We look at ARDS soon, but yes, it can form sepsis. It can result in ARDS for sure, right? So these are few known complications of bacterial pneumonia. We look at ARDS soon, and after looking at viral pneumonia, right? Like I said, there are few clues for you. When you have these clues, most likely organism. I'm not saying this is the only clue. The best clue is going to be culture. You culture, you find streptococcus, you call it streptococcus pneumonia. As simple as that. You culture, you see staphylococcus, you call it staphylococcus pneumonia, right? But there are definitely few clues for you to remember. Okay, you can tell for it to be pneumonia, right? Most of the time in a question, in a long answer or something, bacterial pneumonia, if you have a question saying rusty brown sputum, this is a general term given for almost every bacterial pneumonia, right? General term for almost every bacterial pneumonia. Okay? If you have a history of IV drug abuser, most likely organism is Staph aureus. I'll tell you a simple way to remember this, right? See, chest pain is not a main symptom of pneumonia. It's fever and breathing difficulty, which sputum production is main symptom of pneumonia. So the see, irritation of pleura can cause chest pain, but it's different. It will not radiate to the back. Fine. Okay. So IV drug abuser, why Staph aureus? Staphylococcus is a skin commensal. So if you don't clean properly and keep on injecting, there's a possibility the skin commensal can go underneath and can go to the lung or your even your infective endocarditis. Same thing can happen. IV drug abuse, right? Klebsiella. When you see anything, Klebsiella will produce lots of mucus. Even in cultures, they produce lots of mucus. In the body also, they'll produce lots of mucus, right? If you see anything saying red currant jelly sputum, it's actually an exaggeration. But you see a question that says blood tinged mucoid sputum. Actually, this is the reality. A mucoid sputum with blood tinge here. Fine. We'll come to that. We call this an think of Klebsiella anemia. Atul, you are right in saying that cough and fever is a very generalized symptom. So when I auscultate a patient, right? You auscultate a patient. Do you think a generalized infection will cause bronchial breathing or consolidation? Might not, right? So that's a clue for me here, right? That's a clue for me. If you know that, I can easily say, okay, it's an localized to lung or your alveolar tree, right? It's all of them put together. I suspect that's all, right? Pseudomonas. Pseudomonas, there should be some predisposing factor. Either the patient is neutropenic, immunosuppressed, or most importantly, the patient might having cystic fibrosis. That's one of the important predisposing factor for Pseudomonas pneumonia. Patient has cystic fibrosis or you have an neutropenia. Just one more clue, Legionella. As Dr. Mangta talked about Legionella, there's one particular thing Legionella can grow very well. Okay. So when you have any history of water coolers, ACs, have you seen water coolers? You must have seen water coolers, right? Like a tower fan where you pour water inside. Tell me honestly, if you've ever used a water cooler, when was the last time we clean it? Never clean it, right? Never clean it. So Legionella, AC, portable water coolers, these are extremely important places where it can grow. And it's a spray. That water cooler has the organism which will be sprayed, aerosolized by the same water cooler, you get a hold of it, right? So these are few clues, okay, saying that, okay, these are things which I'm going to see them, right? So all these for clues for saying what the organism of pneumonia is. In general, whatever pneumonia is, the stage of consolidation, everything remains the same, pathogenesis remains the same, unless it's an viral pneumonia or an atypical pneumonia or an intracellular organism, right? Let's see what will happen to viral or atypical. That's different. I'm taking viral as an example because it's easy for us to read virus because we know how virus involves, right? Let's assume route of entry is same inhalation. For any pneumonia, bacterial or virus, it's going to come via the inhalation route only, right? It came inside, came to the alveoli. We have the alveoli here, and let's assume my virus is reached here. Tell me now, uh, there was some cystic fibrosis, the cilia motility is not that much there. So, uh, because of the ciliary dysmotility, ciliary dysfunction, and the very thick mucus, which can happen in cystic fibrosis, that kind of holds the bacteria, doesn't let my immune system act properly. Cystic fibrosis, there are lots of pneumonia which can be predisposed. One of the important thing is Pseudomonas. Now, your virus. came into the alveoli. Do you think they can escape the alveoli and go into the interstitium? Because viruses are very, very tiny compared to the bacteria. Very tiny compared to bacteria. Can they escape to the interstitium? Is there a possibility? There is a possibility. So here, my concern is the virus doesn't stay in the alveoli. Go to my interstitium. The reason why they don't stay in the alveoli is viruses are obligate intracellular organisms. They cannot stay in the alveoli, which is an empty space. They need cells. They try to go to the alveolar wall. There are gaps inside. They escape outside, right? They go into the interstitium. Once they go into the interstitium, again one more question. They will stay in the interstitial space or they go into the fibroblast and they stay inside the fibroblast. They stay inside the fibroblast or some of the cell, right? Once it goes into the interstitium, it goes inside your interstitial cells. Fibroblast primarily. Here I'm not worried about a permeability or a gap. It's an alveolar space. The thing about viruses, virus can penetrate into the desmosomal, hemidesmosomal gaps also. They are very, very tiny, right? I I cannot go via this. When I have two hands, my hand cannot go, but air can go. If I pour water, water can go, right? So the gaps are not enough for my WBC and RBC to go outside. That's what my endothelium or my alveoli is stopping, right? They are very, very tiny thing. They can definitely go inside. Yes, it can go into the pneumocyte also. I'll come to that Atul very soon, right? It can go inside it, right? So now it's gone into the interstitial cells. Now you tell me, let's assume the alveoli. I've drawn the alveoli smaller just to understand that, okay, I'm having an interstitial cell here inside which my virus went and is replicating inside the cell. Now my goal is very, very simple. My immune system should go and destroy the virus. If I have to destroy the virus, what inflammatory cells should come outside? You know the answer? And going back to the second chapter, what inflammatory cells should go outside? It's lymphocytes. Perfect. Not neutrophils. Neutrophils will not help against virus, right? The lymphocytes should help against the virus, right? Okay. So from this blood vessel, lymphocytes came outside. How do you pick up lymphocytes in a biopsy? Going back to the basic science. If you know the first few chapters, systemic pathology is a piece of cake. How do you pick up lymphocytes in a biopsy? Small round blues. All. Now tell me, the small round blue cell will be there in the interstitium or inside the alveoli? It will be in the interstitium, not be in the alveoli, because the focus of the small round blue cell lymphocyte has to destroy my interstitial cells because that's where I have the bacteria, that's where I have the virus or intracellular bacteria, right? So here what happens is I'm going to have round blue cells. That's my lymphocytes in interstitium. Now you're going to help me in two things. Here, my alveoli. Is it normal? Not normal. Normal, right? Do you think air gas exchange can happen in the alveoli normally in these patients? Just here, this is the problem here. Do you think air gas exchange can happen normally? It can happen normally, right? I told in the last pneumonia what we discussed, the entire alveoli has lots and lots of bacteria inside them, neutrophils inside them. The patient coughs. You have sputum with the green color or the neutrophil or the pus. Here, alveoli is clear. Do you think the patient will have sputum production? No sputum production, right? Perfect. So if you take again COVID, COVID is a viral pneumonia. I'm not talking about the complication of COVID. Some of your family members definitely must have had COVID. Did all of them have breathing difficulty? Yes or no? They won't have breathing. Some of them will have, not everyone. Most of the viral pneumonias will solve on its own. It's virus, it's self-limiting. It has to be self-limiting. Once the lymphocyte comes, destroys them, goes away. Patient might have fever, cough, no sputum production. Thing will happen, right? Now let's assume the virus is becoming more and more virulent. I'll just zoom this place. The virus is becoming more and more virulent. Is there a possibility this virus can go and destroy the blood vessel because they are in the interstitium? Is there a possibility they can destroy the blood vessel? Just an assumption. Can they not? If the virus is more virulent than my body, the virus spreads. Let's assume green for virus, different color. Virus spreads, can destroy this, can destroy this, can destroy. They can destroy. We look, keep this in mind. We will see why we had a complication of breathing difficulty in COVID or any of the intracellular pneumonia or intracellular organisms for that matter, right? Let's zoom this out. So this is what is going to happen in an atypical pneumonia. The reason why I'm calling it atypical is I'm saying it's a pneumonia, no breathing difficulty. I'm saying it's a pneumonia, no sputum production. Not typical, atypical. I don't want hospitalization here. Wait and watch. That's more than enough for most of the viral pneumonia, right? So in these viral pneumonias, symptomatology is very simple. There'll be cough. The most important thing is dry cough, fever, and there'll be very rarely, right? Rarely there'll be breathing difficulty. Otherwise, no breathing difficulty. The question comes, how do I diagnose them? Will you even think of pneumonia here? Don't think of pneumonia, right? No one is going to think of pneumonia here because cough and dry cough and fever. Like Atul said, fever and cough is very non-specific unless there's an auscultation finding. That's also a bit difficult here because my alveoli is fine. I don't have that also here, right? Now is where my radiology comes into play. Okay? Again, you're going to answer me. It's all about imagination, right? Once you imagine, everything will fall into place, right? Say, just for understanding, this was my normal alveoli, right? With almost nil interstitium, right? So when an X-ray passed through this, you saw completely black color. That's what we saw. Because I have only alveoli, only air. So this normal, in case of a viral pneumonia, let's see what will happen. It became like this. Can I say it becomes like this? Because my interstitium is becoming bigger, expanded because of lots and lots of lymphocytes inside. Just let's assume becoming like this. Can I draw like this? Just the blue color here is nothing but all the interstitium is expanding here, right? So this is what happens in viral pneumonia. Nothing but you're having expanded intestine. This expanded interstitium, the ideal reason is just due to lymphocytes. Now I want you to imagine you're doing an X-ray of this expanded interstitium, right? Intestine expanded, damage to my fibroblasts, little bit of here and there collagen formation, and lots of cells here. These blue areas, will it be opaque or not? I'm having thousands of lymphocytes, little bit of fibroblast proliferation, everything there. Will they be opaque or transparent or translucent? What do you think it will be? See, this area, alveoli is clear, transparent. This full of lymphocytes, will they be transparent, opaque, or translucent? Just your guess. You've not read radiology, but we have amazing common sense. That's more than enough for me. Maybe I can say translucent to opaque. Yes, it will not be transparent like this, right? So now what's going to happen here is, just I want you guys to imagine again. I'll have a beautiful black color here. That's my normal lung. And now the black color is being disturbed. So what will happen? The disturbance is, I'm going to have here and there and here and there and here and there. I'll have transparent areas, right? Or translucent areas. These translucent areas here are nothing but anesthesia. It's not clear. It's not opaque. It's translucent. Have you seen bathroom glasses? When you go to next time to the bathroom, you will have glasses on the corner. In the ventilator, there'll be glasses will be sliding like this, right? Have you seen the glass? The glass is transparent or translucent. Everything comes from life, surroundings of yours. It's not, medicine is made by a human being, and the human being is going to relate whatever they see. Have you seen the glasses? You must have. Or the HOD room's glass. or the ICU windows glass. It's not transparent, it's translucent. Only the whole of the ICU will be transparent, the rest of the glass will be kind of translucent. That glass is called as a ground glass. So this lung looks like a ground glass. I'm sure you must have heard this in your COVID reports. A ground glass appears. Ground glass appearance, well, just a ground glass appearance. That's how a pneumonia looks. A viral pneumonia looks like that. I can pick them only on X-ray. Generally, I don't need this. Self-resolving. Wait 4 5 days, no breathing difficulty, give paracetamol, body will take care. We will see what will happen when my body can't take care of it. Right? So we know about viral pneumonia. The symptom is different, the pathogen is different because you're obligate intracellular organism, it comes outside. That's all right. So there's one this is the pathogens for any atypical pneumonia. The most common etiology for atypical pneumonia is mycoplasma pneumonia. Mycoplasma is the most common etiology of atypical pneumonia. It's much more common than viruses. Generally not that much concerned about because we ignore them. Like it's coming like a common cold and we go them, right? Important clues for mycoplasma is they often occur in communities, very closed communities, like an epidemic in schools, most likely mycoplasma, uh, or in camps or in prisons. That will be the example for this. Pneumonia outbreak in schools, camps, or prisons, a closed community, think of mycoplasma. And if I have to create a big history, I can easily create this because mycoplasma can result in autoimmune hemolytic anemia. If you remember the cold agglutinin type, if I have a pneumonia with an anemia where I'm having hemolysis, think of mycoplasma pneumonia, right? As a clue again, for me to pick up, okay, I'm thinking about a mycoplasma infection, right? Now we know about both of the pneumonias. Now let's go to ARDS. ARDS is a complication of both pneumonia, whatever it may be, right? You may say, "See, I just want you to." Can you hear me? Sorry. Can you hear me? I changed the screen so my audio went away. Fine. So what I was saying was this is how in future the entire pathology is going to go towards. As of now, I am reporting 20% of the cases in laptops and tablets. I don't report 20% of the cases in my microscope. It's become digital. In the next 5 years, 50 to 60% of the cases will be digital. You can sit from anywhere and report, right? There's a normal peripheral smear. Look at the magnification, how much magnification we have. Okay. Tell me what cell is this? What cell is this? I'm sure you'll be able to identify cell. What cell is this? As a simple normal. I didn't say anything with it. I just repeated whatever I said. I repeated everything whatever I said. Fine. That's a neutrophil. Perfect. Okay. You're going to give me the diagnosis. I'm just going towards normal cells. Then we'll go to the diagnosis for sure. Fine. I want one more cell. I'm searching for that cell. What cell is this? Approximately. You can say what cell is this? A lymphocyte. Perfect. Now, this lymphocyte has the nucleus, right? Compare this lymphocyte nucleus to this RBC size. So tell what is happening to the RBC. Normocytic, microcytic, or macrocytic? Perfect. It's smaller? I'm sure no, it's small, right? Perfect. Now, ignore the WBCs. Look at the RBCs alone. Can I say the pallor is more than one third normochromic or hypochromic or hyperchromic? Hypochromic. Perfect, right? Tabasam has pointed out one more thing as well, right? If you look at this cell, is it elongated? Is it pale or not pale? It is pale and it's elongated. What cell is this? You can see them here. You can see them here. What is this cell? Like Tabasam said, it's a classical pencil-shaped RBCs, right? Pencil-shaped RBC. You can see kind of becoming like a pencil. Elongated, right? As pencil-shaped RBCs, right? You have pencil-shaped RBCs, you have microcytic, you have hypochromic anemia. Most likely diagnosis? Most likely an iron deficiency anemia, right? So I do have entire set of hematology slides like this. I'm trying to get histopathology slides, at least for your undergraduate level. Once we get that, we'll learn whatever you want to learn in microscopy, we can learn digitally, right? Days are changing, and I'm sure in a couple of, if maybe give it 5 6 years, almost every slide will be there in this platform like this, right? These are digital slides, which are mine. Okay, what are these cells? What are these cells? Come on, you guys know this. There are only three groups of cells in blood: RBC, WBC, and what are these? What are these? What are these? Platelets. Perfect. Actually, if you read Robbins, it will be given in Robbins saying that iron deficiency anemia has thrombocytosis, a reactive thrombocytosis. Can I say platelets in this patient is definitely more? But how many platelets are there? Lots of them, right? There are lots of tiny, tiny blue dots, right? So everything what you study can be easily seen. If you're not able to correlate something what you studied, either we are studying wrong or the disease is idiopathic, right? So hopefully in future the disease will not become idiopathic and we will learn every information required for us, right? Okay, let's go. Let's go back to our ARDS. Right. So ARDS is a complication. The full form for ARDS is an acute respiratory distress syndrome. It's a complication of pneumonia, a complication of sepsis. Okay? My life will become much easier just to play with the laptop. Complication of pneumonia or sepsis. An acute respiratory distress syndrome. It's not adult. You will read something called as a neonatal RDS when you go to pediatrics. That's different. It's different. This is an acute respiratory distress syndrome and never ever adult respiratory distress. Right? There are lots and lots and lots of etiology of ARDS. I can call something as acute lung injury, but ARDS is a much more common term used. Right? So there are lots of etiology. If you look at Robbins' an entire table, whatever can cause DIC can cause ARDS. Surgery can cause, mechanical trauma can cause, abortions can cause, pancreatitis, uremia, there are lots of things it can cause. But few things for understanding pathogenesis. The etiology, please don't forget these two etiology. That's very, very important for me. Sepsis, the most common etiology for ARDS, and pneumonia. This is also common etiology for me for ARDS. Like I said, there are many, many things which can cause ARDS. I'm not going to the entire template. You'll have them in Robbins. You can definitely read them. Right? These are the two main etiology for ARDS. Right? The only biggest problem of ARDS is what does sepsis mean? Can anyone tell me what does sepsis mean? What do you mean by sepsis? What do you mean by sepsis? Sepsis, what is sepsis? Sepsis is nothing but bacteremia. Bacteria in blood is called as sepsis or septicemia. Right? The bacteria is not confined to an organ. It's in the blood. Shock is a state of sepsis, right? If I have bacteria going in the blood and dividing the blood, I call it sepsis. That's all, right? Bacteria and blood is sepsis, as simple as that, right? Let's see. Let's take sepsis because sepsis is the most common etiology of ARDS, and let's see what happens to the lung when you have sepsis. Just for understanding, I have an alveoli here and I have a blood vessel here. I have drawn blood vessel longitudinally because I have to draw bacteria inside. That's all, right? I'm having bacteria here. I'm having bacteria in the blood vessel. Let's say this bacteria here, can they cause endothelial damage? Yes or no? This bacteria inside the blood vessel for us, and this is alveoli for us. Can the bacteria cause endothelial damage? It will. It will definitely cause. The first starting point for ARDS is endothelial damage. The only starting point of ARDS is endothelial damage. It's not lung damage, it's the endothelial damage. COVID also caused ARDS. It also will cause ARDS with endothelial damage, like we saw in viral pneumonia. Once it can expand the interstitium, it can go and damage my vessels. So this is the first or the starting point of ARDS. That's why when you had your friends, family members, or patients having COVID, did we do D-dimer? Yes, we did do D-dimer, right? D-dimer is nothing but a fibrinolytic agent. When this fibrinolysis, D-dimer will be elevated. So when endothelium undergoes damage, automatically clot will form. When clot forms, automatically clot will lyse. So by doing D-dimer, I can tell that, okay, endothelial damage has happened 2 days back. So I have to go back and treat the patient aggressively. That's the concept of D-dimer in case of COVID. Fine. Let's come back to this. Once endothelium damage happens, this is going to definitely increase the permeability. It will definitely increase. The entire permeability increases, right? If the permeability increases, there are two things for me here. There'll be more and more and more WBC, and there'll be more and more bacteria. Both WBC and bacteria will happen in two places. Will happen in the interstitium because my blood vessels are being destroyed, right? It'll happen in the interstitium. That's not my major concern, but it'll also happen in the alveoli. There are more WBC and bacteria, both will increase in the alveoli. Let's assume it's going to be like this. Just bacteria here. The green ones are the bacteria, both the places, and also my WBC. So sepsis is a low grade infection or a very high grade infection? What do you think sepsis is? Low grade or high grade? Sepsis is definitely a high grade infection, right? So in a high grade infection, the amount of organism will be very, very high. But my neutrophils is not that high. Again, going back to your second chapter, when the organisms are very, very high, my neutrophils cannot go and eat every organism and destroy it. So it had one more method of destruction. What is it called as? Since the bacteria is very huge, I cannot go and eat. So what did neutrophils do? They ruptured. What is it called? Can you remember them? The neutrophil ruptured. What is it called as? So here, because the extremely high bacterial load, come on, you know that. Recollect that. I gave you an example for that, saying that when in a final year exam, you're not able to read the entire portions, so you ask your friends' help, and everyone vomits whatever they know. Like that, my neutrophil ruptures. Do you remember that? Do you have you heard this name? NET? If so, what is NET? Neutrophilic? Sure, you must remember. Extracellular trap. Have you heard this? Yes or no? You must have for sure. So here, the bacteria is very, very high. My WBC cannot destroy them. So my WBC degranulate, right? Neutrophilic extracellular trap is nothing but degranulation of WBC. When WBC is degranulate, entire thing is going to go outside. Will I destroy bacteria? Yes or no? Will I be successful in destroying bacteria? Obviously, yes, I'll be successful in destroying bacteria. Will I also destroy my alveolar epithelium? Because it's extracellular, right? And will the alveolar epithelium also be destroyed? The collateral damage. My cell also will be destroyed. My cell is destroyed. my neutrophils are destroyed, my bacteria is destroyed, and there's a endothelial damage. Will it cause fibrosis exudate? It will. This degranulation has multiple effects. Yes, it will kill bacteria, but at what cost? It will also kill pneumocytes. That's a side effect here. It's a neutrophilic extracellular trap. Post damage will be very, very high. Not just that, WBCs also will destroy. Plus neutrophilic extracellular trap, we call them beneficial suicide. When it ruptures, it destroys. Not just that, I'll have fibrin. I'll have fibrin also there because of the starting point is endothelial damage, right? A dead WBC, a dead bacteria, a dead pneumocyte, and fibrin. What do you think will be the color? Pink or blue? Everything here is dead. What do you think will be the color? Pink or blue? What do you think will be the color? Pink in color. Perfect. So now let's go back to our first chapter. You want to name the disease. If you're not going to learn, we're going to name things. If something is pink and I'm not sure what it is made of, what was the term we gave? I don't know what it's made of. I'm not sure which gave more pink color, dead bacteria or dead pneumocytes or dead WBC or my fibrin. Something is pink in color. I don't know what it is made of. We generally going to call them a fibrin-rich exudate. We have one more term for them. We remember them. I just want you to remember general path. Perfect. Hyaline. When something is pink in color, I don't know what it's made of. I'm going to call it hyaline. Where do you think this hyaline is going to be? Inside the alveoli or outside the alveoli? It'll be inside the alveoli, right? Perfect. Because everything here happened inside the alveoli. Let's assume this is my alveoli and in hyaline. It's inside the alveoli. It's not outside. Because all the bacteria were inside. WBCs were inside. Interstitium, like I said, I'm not much worried about. I'm worried about this alveoli only. I'll tell you why I'm worried about alveoli more. I'm having lots of destruction here. I'm having this fibrin-rich exudate lining the alveoli like this. And this, I'm going to call it an hyaline membrane. This hyaline membrane, once my hyaline membrane is formed, do you think the alveoli can breathe properly? There's a mechanical barrier, right? You cannot breathe properly. Never breathe properly. Here, the patient will be symptomatic. The patient will have respiratory distress. Will for sure have respiratory distress. So this is my first stage of my my ARDS. We call it an acute stage of ARDS. Generally, acute stage of ARDS happens within 2 to 3 days of onset of sepsis. Once my endothelium is damaged today, within 3 days you will have breathing difficulty for sure, right? So I have breathing difficulty. I have to awake. Okay, something bad is happening. Let's go and intervene, right? So let's assume someone has not intervened. Someone has not come to a doctor, and the patient is staying at home taking paracetamol, thinking everything will become all right. I'm having such a huge amount of tissue injury and tissue damage. Any day at any place, tissue damage is always followed by what? Tissue damage is always followed by only one thing, which is the routine. Tissue damage is always followed by healing. Healing is always by fibrosis, as simple, right? Let's see how it look in hyaline membrane. My first stage, fifth stage. Again, I'm drawing the outline of alveoli. Can I say that alveoli wall is lined by pink membrane? Though not completely, a pink membrane on the top, right? That's your hyaline membrane. That's your hyaline membrane, right? That's what look in acute stage of ARDS. Now it will be followed by healing. Healing is always by the same person. Tissue destruction, healing by fibrosis. It's always healing is the same. The healing stage of ARDS, we call them an organizing stage of ARDS. For healing to start, what do you think is the first step? Fibrosis is the last step. Once inflammation goes away, who will come and remove all the inflammatory debris? You know that person. Who's that? Macrophage. Macrophage will come for sure, right? So once healing starts, there's nothing but a healing stage of ARDS. Macrophage will enter. Macrophage removes the hyaline membrane. The first thing is hyaline membrane will not be seen in case of your healing stage or organizing stage. It will be completely clear. Next is obviously healing. Healing, one is regeneration, one is fibrosis. Both will happen in any healing. It will regenerate and it will undergo fibrosis, right? This healing will result in regeneration for sure. Now tell me, it's a logical question, nothing to do with medicine or anything. Which pneumocyte do you think is more important for an alveoli? Type 1 or type 2? We know both function. One is going to help an air gas exchange, one is going to create surfactant, which makes them a stable alveoli. So, which you think is more important for any thing? Type 2, perfect. So, who will come back first? Type 2 will come back first, right? My body reacts based on the importance, that's all. The regeneration will be more regeneration of type 2 pneumocytes. I'm not saying type 1 pneumocytes will not happen, but type 1 pneumocytes will be very subtle. Predominantly a type 2 pneumocyte hyperplasia and very subtle type 1 pneumocyte hyperplasia. This is what happens in regeneration. Second thing automatically is fibrosis. Again, you're going to answer me. When I say fibrosis, where do you think fibrosis will happen? In the alveoli or in the interstitium? Where do you think fibrosis will predominantly happen? Alveoli or interstitium? The alveoli is air. I cannot form fibrosis in air, right? Not magician, right? For alveoli cannot have fibrosis because it's air, only air. I need a framework or a base for fibrosis, right? So definitely fibrosis will happen, and this fibrosis, interstitial fibrosis. Okay. Now let's see what will happen to the alveoli. Membrane will be gone, right? Who will remove the membrane first? Macrophage will come, remove the membrane. Only then healing is going to start, right? Fibrosis will predominantly happen in interstitium. This interstitium is where I had fibroblast. So that's where fibrosis can easily happen and more commonly happen, right? I hope it's clear, Tabasam. Now we have the alveoli. Just for understanding, I'm having predominant type 2 pneumocyte hyperplasia. Like I said, it's not that I don't have type 1, predominantly it's type 2. It has the Hobnail appearance and everything. Type 1 is also there. Type 1 is also there, but predominantly type 2 hyperplasia. And just for understanding, alveoli, the interstitium is going to have fibrosis. Fibrosis. Now tell me, in this stage, will the patient have respiratory distress or no? Assuming both type 1 and type 2 is present, will there be respiratory distress here or not? Yes or no? Will there be distress or not? Yes. I'm going to get answer. Will there be distress or not? Okay, Tabasam has gone for no. Others, who is online? Vinay, Atul, will there be distress or no? I wanted to think. Don't be shy of answering anything. It's okay to make mistake here. Again, Vinay, no. Okay, now let's come. I'm going to ask you one more question. Perfect. You commented one thing. It's about not getting the right answer. It's about learning. It's a learning experience. That's all. Now you are only going to tell me, I'm having an alveoli. Surrounding the alveoli, I'm having fibrosis. Can this alveoli expand? Can this alveoli expand? Can't expand. So if the alveoli cannot expand, will there be a respiratory distress? There will be a distress, right? This is not a problem with the alveoli. My problem is in the interstitium. My alveoli cannot expand for sure. So here also, since there's a reduced expansion of alveoli, the patient will develop distress, respiratory distress. Now tell me, this respiratory distress due to fibrosis, reversible, irreversible? Reversible or irreversible? Fibrosis, irreversible, irreversible. That's my biggest problem with ARDS. The distress is irreversible. Can't do anything. No one can do anything. It will be irreversible because it's fibrosis. No one can take back fibrosis again, right? Let's see how it looks in my microscopy. Then I'll come back to this again. You have a beautiful normal alveoli here, entire alveoli here, entire lung undergoing fibrosis, pink color fibrosis on and completely damaged. In this image, I could say half of the lung is damaged. Atul, even in bacterial pneumonia, the interstitium is where fibrosis will start to happen. I'm having a damage here. It will be close to the wall. It will completely compress the alveoli. It will make it consolidated. In this space, never fibrosis can happen. It will happen from outside. It will compress and destroy them. Right? Okay. Now, if you look at COVID again, the way to treat COVID was we gave. Well, how did we treat COVID? What was the magic drug for COVID? What is the magic drug for COVID pneumonia? I'm sure you must have read for sure. Maybe you must have been in your 11th, 12th standard, enjoying your home, because it's work from home and study, no schools. How did we treat COVID? We gave one drug, magic drug, uh, hydroxyquinoline. Those are all experimental drugs. Finally, we gave only one drug. We gave steroids. Yes, that's what we gave. Everyone with COVID had steroids. Steroids helped them. So COVID's treatment came from chapter of general pathology. It's fibrosis. What was the treatment for keloid? Keloid was also fibrosis, right? Excess scar formation. Okay, steroids. So what I have to do is everything is about timing. So before this forms in this stage of COVID, when I gave steroids, fibrosis formation will be reduced so that I can prevent the patient becoming mortal. That was my ultimate goal. Let's say I was not able to do that. The patient had fibrosis. I'm not able to do anything. The only way to treat this is put the patient on ventilator. Not just ventilator. See, ventilator is nothing but a machine which forces air inside. It's ventilator plus positive pressure. You must have heard about this positive pressure ventilation or an high flow oxygen. The problem with ventilator is if you put the patient on ventilator for 14 days continuously, this will result in ventilator associated pneumonia. When there's a ventilator associated pneumonia, what will happen again? What will happen again? I'll come back to your question, Sebastian. It will again cause destruction, fibrosis, the circle. I can't do anything. You must have seen movies in any language. If a patient is in ICU, the doctor will come and say, I can say anything after 48 to 72 hours. That's a real statement. If you have a patient suspected ARDS, you can't do anything. Please accept that we are not gods. We are professional with medical knowledge. I'll transfer the medical knowledge to the patient. I am not God. I cannot save. Body heals, I treat. I don't even heal, treat. That's all, right? So this, if it happens, the mortality of ARDS even in 2023 is close to 50%. Can't do anything. The only way is lung transplant. That's not so easy and that's not possible at all, right? Tabasam, bacterial pneumonia will not end in ARDS unless and until it's very, very virulent organism. Immunity is very low, no treatment. Yes, outcome. One of the worst outcome is ARDS. Same with your COVID. One of the worst outcome is ARDS. 1% will cause ARDS in bacterial antiviral pneumonia. 1% is very less, right? COVID had a problem because it affected 1 billion people. 1% of 1 billion people is high. That's why we had a trouble with COVID. That's all, right? Okay. That's about ARDS, a complication of pneumonia, sepsis, and everything. Right? Let's just have a quick look over maybe one of COPD, and then we'll call it a day. Right? What do you mean by COPD? COPD is chronic obstructive lung disease, right? That's what COPD means. The chronic obstructive lung disorder. Pulmonary disorder or lung disorder. P stands for your pulmonary disorder, right? It's chronic obstructive pulmonary disorder. Obstruction can happen in any place. It can happen in the bronchus, it can happen in the bronchioles, it can happen in the acini. That's my alveoli. Anywhere when the airflow is being obstructed, I call it COPD. You already know one disease where bronchus will squeeze and it will not let the air enter inside. What is the disease called as? A disease where bronchus starts squeezing and the air will not enter properly. We read them in general pathology in type 1 hypersensitivity. Asthma, right? Asthma is also a COPD, right? So here, when I say chronic obstructive pulmonary disease, it's just airway obstruction, that's all. I have multiple disorder. I can have asthma. I'll not be going into much in details about asthma. Superficially, we'll see sometime because we know about type 1 hypersensitivity. Same thing, whatever you read in type 1 hypersensitivity, right here. Symptom add-on, respiratory difficulty, wheezing. That's all. Nothing required as an asthma, right? Here, the obstruction happens in the level of bronchus. Symptomatology is simple. The important symptom is wheeze. And the pathogen is as simple as your type 1 hypersensitivity. We read in type 1 hypersensitivity, immediate phase, late phase, eosinophils. We also read the Charcot-Leyden crystals. Everything will be seen in asthma. Symptom allergy, that's all. Hypersensitivity, that's it about asthma, right? Nothing much required in asthma. Then emphysema. Emphysema, the obstruction happens in the level of sinus or the alveoli. Respiratory unit is called as sinus. We look at emphysema very soon. We have something called chronic bronchitis. It's an inflammation of the bronchus. When bronchus is inflamed, obviously it'll if it's chronic, I'll have tissue destruction healing by fibrosis, which will make the bronchus smaller, right? So here also is a problem in the bronchus. Okay, I do have something called as bronchiectasis. Sinus is you must have heard about the multiple divisions of the lung tree in your anatomy, right? It subdivides into 17 or 20 divisions. From the mainstem bronchus keeps on dividing. The unit beyond the terminal bronchiole, we call them an acini, right? Acini is nothing but the area beyond terminal bronchiole. This area beyond terminal bronchiole, we call it an acini, right? It's an anatomical division, subdivision, that's it, right? So we have something called as bronchiectasis. What does ectasia mean? You definitely must have heard about ectasia. We did read about ectasia in your blood vessels. We call them telangiectasia. Telangiectasia. What does ectasia means? Ectasia means dilatation, right? Ectatic dilatation, right? Here the bronchus is going to undergo dilatation. Once the bronchus undergoes dilatation, it's a huge space. It will definitely not let the flow of the air properly. That's bronchiectasia, right? It's a chronic inflammation. It's more of a clinical thing than a microscopic finding, right? And there's one small airway disease called as bronchiolitis. It's same. The inflammation in bronchus is bronchitis. The inflammation, if it happens in bronchiole, bronchiole is again an anatomical subdivision. Bronchus subdivides, then becomes bronchioles, then becomes terminal bronchiole, then become acini, right? Bronchiolitis can also happen similar to bronchitis due to smoking and other causes, right? So these are the five major subdivisions of chronic obstructive pulmonary disease where we know about asthma that might come in an exam. Emphysema will read, chronic bronchitis will read. Bronchitis will add a little bit of important findings, not much in detail. Bronchiolitis is not required much. It is more of a pediatric finding, or it's something which is uh, very difficult to diagnose without an investigation, right? So for undergraduate, something which can be diagnosed on a clinical examination and symptom is what is being mainly focused on, right? Let's go to emphysema. We'll look at emphysema today, and then we'll call it off today. Just maybe 10-20 minutes max. Emphysema, by definition, I said it's going to destroy the acini. By definition, emphysema is an irreversible destruction and dilatation of the alveolar spaces emphysema. Right? An irreversible thing. It's an irreversible destruction and dilatation of acini. When I say acini, it's distal to my terminal bronchiole. It's implied. It's distal to my terminal bronchiole. I call it emphysema, right? Okay. So let's see pathogens of emphysema. It's a very simple pathogenesis. Let's see how my body is going to react to a smoke. If I know how my body reacts to a smoke, I easily know about emphysema. So when you inhale smoke, whatever may be the smoke, it can be a tobacco smoke, it can be an cooking related smoke, it can be your vehicle smoke, pollution, anything. Right? When any person inhales smoke, you or me, what's going to happen is smoke will always, once it enters to my alveoli, smoke has the capacity to trigger WBCs. Smoke will let WBCs release its enzymes. It will make them degranulate. In other words, one of the important enzymes which comes outside due to smoke is elastase. What does elastase do? As the name says, elastase is going to destroy elastin or the elastic fibers, right? The biggest advantage of lung is elasticity. Alveoli is an alveoli because it can expand, it can contract. It can expand, it can contract, right? So if an elastin is gone, do you think it can expand and contract? This is elasticity. So it will not be like a balloon anymore. It's like gone. Not come back. It's completely gone, right? So this is what results in emphysema. The permanent destruction of the wall of the alveoli. It's not letting them breathe in and breathe out properly. It becomes like a sac. It's not anymore breathing and breathing out, right? This results in emphysema. Okay? Now tell me, if this pathogenesis is true, if it's true, am I right in saying that you and me also will have emphysema? Because invariably we inhale smoke. I'm not saying you're an active smoker. You live in any country in the world, you will inhale smoke. It's part and parcel of the environment, right? So definitely everyone here should have emphysema. You are not having emphysema? No, I'm not having emphysema. So someone is protecting me. If the protection is not there, everyone in the earth will have emphysema because smoke will trigger WBC, will release elastase, right? The person who's protecting us, if you believe in God or nature, someone who's created us is a very, very, very intelligent person. They have thought through every second, every cell. They have thought through that we'll be living in a polluted environment long before pollution was discovered, right? Okay? No, I'll tell you what happens. See, now elasticity is gone. How to explain to you this? Let's say you're having an elastic pant, right? Elastic is gone. You're expanding it. Will it contract? Not contract, right? The pant elasticity is gone. It will not contract. It will stay expanded. When elasticity is gone, when I inhale, it will become bigger. It will come back to normal state. That's what will happen when empty elastic is gone, right? Perfect. Great. The person who is thought through is has something called an anti-protease. So what happens is everywhere when you inhale smoke, elastase will be released. But my lung has good amount of anti-protease. The anti-protease here, I'm sure we have heard this before, called as alpha 1 antitrypsin. So an anti-protease with an alpha 1 antitrypsin, this alpha 1 antitrypsin will destroy elastase. So it's simple. You inhale smoke, I inhale smoke, WBC will release elastase. So once elastase comes, alpha 1 antitrypsin destroys elastase. So that my lung is safe. So that my airway is safe, I breathe properly in spite of inhaling smoke. So this is what happens in normal tissue. It's not emphysema, right? Now we'll see what will result in emphysema. Because my concern is emphysema, right? Simple thing. Either if I'm going to be an active chronic smoker, every smoker is chronic. There's no chronic smoker. Smoker means chronic, that's all. Any person who's going to smoke every single day will make sure they will release smoke more than what my alpha 1 antitrypsin can protect. Result in emphysema. Or is there a possibility by nature, by genetics, if I don't have the enzyme, can I have the disease? Obviously, right? Second is, I will use AT for antitrypsin, alpha 1 antitrypsin deficiency. As simple as that. Either I smoke a lot and make sure my antitrypsin levels are being saturated, it destroys, or there's no antitrypsin, automatically even a normal pollution can result in emphysema, right? My etiology related to my normal and pathogens, right? Now let's see the subtypes of emphysema. Subtypes of emphysema is an important question for you. If it comes in exam, don't memorize. It's very simple. I know normal. You are going to tell me each and everything related to the abnormality. Let's assume this is this is my terminal bronchiole. Anything beyond terminal bronchiole is termed as acidic. right? If this is arsenic, let's assume you're smoking, or let's assume there's a balloon. You're putting smoke into a balloon. You must have played with a balloon, right? Balloon generally has sand. That's what causes a sound in the balloon. When you're kids, you must have played. So when I put anything inside a balloon which is inflated, where do you think they will get deposited? In one or two? I'm just throwing something inside to an inflated balloon. Where do you think the particle will get deposited? One or two? Just throwing something inside. Where do you think it will be deposited? It'll be deposited in the one, right? It'll definitely be deposited in the most dependent part. I'll just repeat it once again. It's an inflated balloon, right? It's an inflated structure. I'm throwing something inside. It goes to the most dependent part. It will not go to the tip. It will go to the most dependent part. It will come in this part only, right? So which means when a person smokes inside, any smoke coming inside will come and get deposited here. The particles of the smoke will come and get deposited here. There's a possibility some of them might go here, but majority of them will deposit here, right? So which means any person who smokes, which part of asthma do you think will be destroyed? Center, periphery. When a person smokes, it will be mostly centri. We call them centri acinar emphysema. So centri acinar emphysema, my alveoli will be like this. The center part of the asthma is going to become dilated because center part of the asthma, right? Let's say if a person has alpha 1 antitrypsin deficiency, no one to protect. If there's no one to protect, where do you think there'll be destruction? Throughout or in one particular part? I don't know anyone to protect at all. So even a tiny part of particle goes to tip will destroy it because smoke will automatically release your elastase and everything, right? So there's no protection, which results in an emphysema, which I'm going to turn this, and acinar emphysema, where my entire alveoli is going to become like this. And it's completely destroyed, right? Way to derive it. There's one more type of emphysema, distal acinar. Okay? So distal acinar emphysema is the distal part of the acina is getting destroyed. Only this part. This also is due to smoking only. The reason why in some people it happens like this is if a person is going to smoke too much, the particle can go to the end. So it's based on the dynamics of smoking, right? So if it's going to go to the end, the particle is going to stay there. Dyslexia, bit rare. Centration are very common. Panesar happens in alpha 1 antitrypsin deficiency, right? So this is how we classify emphysema. It's an anatomical classification, very easy to remember. It's based on the arsenic, right? So if I know century and pan, how it's been formed, we can easily know the differences. This is due to smoking, like we saw. This is due to alpha 1 antitrypsin deficiency. Second, which do you think is more common, century or pan? If something is due to smoking, that's the most common subtype. Obviously rare. Which of these do you think will have a family history? Obviously, family history. Sorry, pan is will have family history. Century will not have family history. But this will have family history because it's genetic. Will have family history. Century smoking related might not have family history. It's smoke, right? Smoke generally involves the upper lobes of lung. The smoke, when you smoke obviously goes up, right? So here, upper lobes of lung are more involved more compared to the lower lobes of lung. In pan SNR, it is normal in century SNR, but the patient's smoke particle is overriding the normal capacity. Let's say that normal alpha natrium can utilize 10 cigarettes, just for an example. Suppose it's going to smoke 20 cigarettes, it definitely override the capacity. The amount is normal, but it's being destroyed in excess. Yeah, for some unknown reason, lower lobes are involved. The genetic deficiency, right? There's one clue. One clue is for me family history for sure. Second clue, it doesn't affect lungs alone. Do you know any other organ where alpha nitrogen will cause damage? You know this organ. We have read about this organ and the finding in my our first chapter. And remember that it affects lung as well as it affects liver. It also causes liver failure. If you do you remember the PAS with and without diastase? PAS positive, diastase sensitive, diastase resistant. There we read that PAS positive diastase resistant granules in the liver is seen in case of alpha 1 antitrypsin deficiency, right? That's a clue for me in a clinical scenario. Family history present, lung and liver damage, panesner. Family history not there, smoking related, centriesner emphysema, right? I'll show you two images. You can tell me which is centriesner, which is panesner. Just before that, answer this question. That makes our life much easier. In these two, where will you see normal acini and dilated acini? Centri or pan? Which will have both normal acini and dilated acini? Centri or pan? Centriesner. That's all. Right? That's enough for us. This both images are from Robbins. You're going to tell me which is normal, which is abnormal. This image has only dilated acini or both normal and dilated. We'll just compare this image. I'm drawing, highlighting some area black in color and some area red in color. Black color is normal or dilated. This makes it much easy. Black is normal or dilated. Black is normal. That's how normal lung looks. Obviously, what is this? This is dilated. It's written here, emphysematically dilated, right? So this has both normal and dilated. Now compare with this. Can I say this is no normal at all? Everywhere. Everywhere dilated alveoli. Compared to this is your normal alveoli, right? So the first image here has both normal and dilated alveoli. This is how centriacinar emphysema looks. So pan-acinar emphysema looks completely dilated. They are both normal and abnormal. I call it centri. Only dilated alveoli, I call it pan-acinar emphysema, right? That's one subject. Second thing for me is that the third one is your distal acinar emphysema. This also is due to smoking, but it's rare compared to my centriacinar emphysema due to smoking only. This became very important for an MCQ point as well as in a real life. Real life it's important because it has a very dreadful complication. Because of that it became important, right? Let's see where will the distal acinar emphysema really matter for me, right? Let's assume this is my lung. Alveoli and acini is like this. Distal acinar will be like this. The distal part of acini is going to become bigger. It's going to become like this. Just let's say, let's raise this part. So how do you think the patient will present? Can I say this patient, this part looks like a bulla on the surface of the lung? This listener emphysema also has other names. We call them as paraseptal because it's close to the alveolar septum, the pleura, or we call them an bullous emphysema. The alveol is completely dilated and becoming a bulla. Is there a possibility the bulla can rupture if someone it's trauma or spontaneously? Can the bulla rupture? It can rupture, right? Definitely a possibility bulla can rupture. If bulla ruptures, right? Let's assume if bulla is rupturing, the person inhale. Where do you think the air will go? Will it stay in the alveoli? It will go outside the alveoli. The bulla's rupture, and I'm inhaling air. No, no, I'm not saying that. See, when I say bulla's undergoing rupture, lung is there. Outside the lung, I have pleura, right? That part ruptures. That's all. When bulla ruptures, entire thing doesn't rupture. Okay, you're asking about the sports trauma. Okay, let's assume this. You are blowing a balloon. It's like a balloon, right? Can a balloon automatically rupture? I don't want a trauma also, right? I'm going to cough. That also can cause rupture. It's a force. It's a very thin bulla. It can rupture with dynamics of the force. It can spontaneously also rupture. So once the bulla ruptures, the air goes into the pleural space. That's dangerous for me, right? This bulla can rupture. The rupture can be spontaneous or it could be due to trauma. If it ruptures and when the person inhales or when the person breathes, perfect. The air enters pleural space. It's not going to stay in the alveoli. Air is going to enter pleural space. It's a concern for me. It's not just pneumothorax. Again, imagine and answer this question. I have a bulla like this. This bulla is an alveoli, like a balloon. The balloon is ruptured here. I'm going to push in air. The air came to my pleural space. When the person is going to expire, let out the air came inside. I'm going to have expiration. During expiration, am I right in saying that there's a negative pressure in the lung? That's what helps me in expiration. You must have known the dynamics, right? During expiration, what do you think will happen to the bulla? If there's a negative suction pressure, will the bulla collapse? Right? Again, I inspire, it'll open, air enters, dura. Expiration collapses. Air cannot go back, right? So with each respiration, what will happen to the air in the pleural space will become more or less. Air enters this pleural space during inspiration and during expiration, the bulla collapses. So air cannot go back outside into my bronchial tree and I cannot expire back, right? So because of this, repeated inspiration expiration, the bulla keeps the pneumothorax keep on expanding. So we call them an tension. If air in the pleural space keeps on expanding, what will happen to the lung? Will the lung collapse? Right? This will result in collapse of the lung. There's lots and lots of pressure in the pleural space. It will obviously result in the collapse of the lung, right? If the lung collapses, it's a very emergency situation. How do you diagnose? Just one diagnosis, treatment, and then we are done. How do you, treatment you already know. I'll tell you how to pick the treatment. How do you diagnose? Can't breathe is difficult. Shift is fine. See, shift has lots of thing. Pleural effusion also will shift. The best way to diagnose is, I'm going to just extrapolate what all Tabasam said. You will have absent breath zones on one side. Person is breathing, but air is not entering this part at all because the entire lung is collapsed. Absent breath zones is a classical diagnostic feature, right? The diagnosis based on symptom is same breathlessness, difficulty in breathing. When you see any question saying absent breath zones on auscultation, there's no breath zones here, which means I'm having a tension pneumothorax in this side. I have to treat it immediately. The treatment is simple. Good doctor fans. The introduction scene is tension pneumothorax. How did John Murphy treat it? You're a good doctor fan, you know the treatment. Treatment is you have something called as an intercostal tube drainage. Simple. What's happening here is the pleural space having huge amount of air via inspiration. Best way to treat is put a hole, take the air outside. In the good doctor introduction scene, there'll be a trauma-related lung rupture. Same problem. You put a tube, entire air will come outside, so slowly the lung will expand back to normal. Right? That's all. It's as simple as that. Right? So this is what image of bulla is. This bulla can rupture. When it ruptures, the air enters your pneumothorax, the pleura, which results in pneumonia. Right? So these are three different types of emphysema: centrifugal, panacenar, paraseptal, or distal. Right? These are three different types of emphysema. There's one more emphysema. We just name it. It's not required if you're going to write an um, theory exam. Something called an irregular emphysema. Ignore this. Rarely here and there you have emphysema module. They are mostly asymptomatic. That's why I said ignore them. These can be picked up on postmortem. That's all I see them. You won't see them as a patient. The type of emphysema called irregular emphysema is generally postmortem finding, very subtle finding. Right? Those are different types of emphysema. So in this class today, we saw about pneumonia, ARDS, and one COPD as well, right? So look at the other COPD, pneumoconiosis, and lung cancer in the next lecture. If you have any doubts, do let me know. I will call doubts. As usual, we don't. Okay, what does trypsin do? Where have you heard trypsin? Good question. Where have you heard trypsin? You will answer the question, Atul. Where have you heard trypsin? You must have heard the word trypsin, chymotrypsin. Which organ produces trypsin, chymotrypsin? The answer. Pancreas, right? Pancreas produces chymotrypsin, right? What is the function of trypsin in pancreas? It activates protein, right? Pancreas way of activating protein is trypsin and chymotrypsin. So trypsin activates protein. So this is an anti-protease. So we call them antitrypsin. So it's a terminology given, right? Anti-protease and antitrypsin, alpha 1 antitrypsin, right? I hope that will sort it out. All right. Any other doubts? Let me know. If you have any doubts, as silly it may sound, please do answer. If I know, I'll answer. If I don't know, I'll definitely read back and I'll come back to you. Syllabus, I'll try to complete it by October end. Might be a little bit more ambitious. By November 15th, we most likely we all will complete the syllabus. Hopefully, all the second year. Okay? Fine. There are no more queries for today. Good night. Have a nice